Hello, my name is Dr. Stephen Chan, and I am a member of the Psych Congress Steering Committee. It's my pleasure to welcome you to this session titled Improving the Therapeutic Management of Schizophrenia, a focused conversation on management of weight gain and metabolic disruptions. This session is supported by educational grants from Alkermes Incorporated and Intracellular Therapies Incorporated. While I introduce the speakers for this session, if you haven't already, please take a moment to answer the polling questions you should see on your screen. Depending on the device you're using, the questions will either appear to the right of the live stream or below. These questions will be asked again at the end of the program. We appreciate your participation in them. And now, let me introduce our speakers. Please welcome Dr. Christoph Correll, MD, Professor of Psychiatry and Molecular Medicine at the Hofstra Northwell School of Medicine and an investigator, Center for Psychiatric Neuroscience at the Feinstein Institute for Medical Research and the Medical Director of Recognition and Prevention Program at the Zucker Hillside Hospital at Northwell Health in New York. And joining him is Dr. Sanjay Rao, MD, the Associate Clinical Professor of Psychiatry and the Associate Residency Training Director at the University of California, San Diego, VA San Diego Healthcare System in San Diego, California. Both speakers will be presenting their session live, and at the end of their presentation, I will come back to pose some questions from the audience. So you can type in your questions in the Q&A box, as well as upvote questions submitted by other attendees if you want to see their question answered. We will try to answer the most popular questions with the time remaining at the end. So without further delay, let's begin the session.
Excellent. Thanks very much, Steve, for the kind introduction. And thank you, Sanjay, for joining me in this really exciting session. I think you're in for something really valuable. Before we go into the content, here are our faculty disclosures. I'm an advisor, consultant, data safety monitoring member, and have other roles for a number of companies who are fortunately still operating in the brain. You may have realized that many companies, big pharma companies, have left the CNS space because it's so hard to get new medications, mechanisms of actions approved and beat the placebo effect. So we're grateful that our partners are still working on finding new solutions to very pernicious problems. And Dr. Rao has been a Speakers Bureau member for the companies mentioned on the slide. We have some additional disclosure. We wanted to make this as up-to-date as possible. So we're talking about some agents that have not yet been approved, that are either close to approval or are in late-stage development and are exciting because they represent very new mechanisms of action. And we want to educate you on that. They also have advantages in having less cardiovascular problems than many of the available antipsychotics, which is one of the foci of today's program. So these are obviously off-label. The learning objectives for today's sessions are to evaluate new and emerging antipsychotic agents for the management of schizophrenia in terms of efficacy, safety, and adherence, identify factors that contribute to non-adherence to medication regimes and the downstream consequences of suboptimal schizophrenia care, and finally, to describe potential mechanisms for antipsychotic-associated weight gain and metabolic disorders to develop strategies to mitigate iatrogenic effects. So in more granular detail, what we're going through in 2 sessions, and Sanjay Rao will be the first presenter, followed by me. And Dr. Rao will present the diverse psychopathology and symptomatology of schizophrenia, talking about first and second generation agents and therapeutic challenges, as well as antipsychotic associated metabolic dysfunction, which has really taken center stage in our concerns for patients' well-being. And then I will be following up with novel treatment strategies on efficacy, safety of new and emerging agents, including Lumateperone, Caplyta, which is the drug that was most recently approved, December 20, 2019, the latest antipsychotic, followed by ALKS 3831, combination of olanzapine plus samidorphan, which will actually have its R&D in November, and maybe the next approved antipsychotic. And then two not so postsynaptic dopaminergic blockade-related agents that are in development, Pimavanserin and SEP856. And then finally, we'll talk about real-world tactics and strategies for addressing comorbidities and mitigating particularly cardiometabolic adverse effects, come up with some conclusions, and then we depend on you to fire lots of questions, which you can already do while you're watching the program. Don't sit on them, shoot them to our moderator, and then we'll be engaging in hopefully a lively discussion, despite the fact that COVID-19 is now in 2020 and preventing us from meeting in person. So I'm handing over now to you, Sanjay, and look forward to your presentation.
All right. Thank you so much, Christoph, and thank you, Stephen, for that kind introduction. And Christoph, it's always a pleasure to be able to share this space with you. So I'm a clinician educator by profession, and so I'm, of course, going to start off with a case to frame some of this discussion. So you can look at this case, or you can substitute your own case that has similar features. A 21-year-old male with a diagnosis of schizophrenia. He's showing up now for his regular outpatient clinic visit. A little bit about his past. He was diagnosed a couple of years ago during his first psychotic break. On that diagnosis, he had the really kind of classic presentation of auditory hallucinations and prominent delusions. And at the time, he was also noted to have a 1-year prodromal period. And during that time, he dropped out of college. He stopped seeing his friends. Now, fortunately, his parents are with him for this visit, and they report that he mostly stays in his room. He showers maybe once a week. He doesn't really talk to his family or friends. He doesn't have any hobbies or activities. And when you look at him, he's staring at the floor. He doesn't make much eye contact with you. He's pretty slowed down. He's superficially linear. He can answer your questions, but they're really short answers. There's some speech latency. And you note that he's really blunted. There's not a whole lot of expression going on there. There's a little bit of a delay in this slide going forward. Let's try that again. Oh, there we go. So we can go back. Okay, all right, here we go. So one of the reasons I used this case was to help demonstrate the variety of symptoms that you can see in schizophrenia. So historically, we give a lot of attention to positive symptoms, things like hallucinations and delusions. And this is not surprising. Those are, after all, the criterion A for schizophrenia diagnosis. But as we've really learned over the years, schizophrenia consists of multiple symptom domains. There are negative symptoms, there are cognitive symptoms, affective symptoms, even motor symptoms. And although there's this common misconception that the illness starts off with positive symptoms and then moves towards negative and cognitive symptoms, in reality, the negative and cognitive symptoms are typically present pretty early, and often they're present even before the positive symptoms. This is not new knowledge or new understanding. You can look back at the earliest descriptions of schizophrenia from Kraepelin and Boiler, and they talk about avolition and anhedonia presenting fairly early in the illness. And any of you who've talked to a patient about their prodrome already intuitively know this, because so much of the prodrome consists of negative and cognitive symptoms. In this case and in others you've probably seen social isolation and anhedonia and worsening school performance. And so, although historically the positive symptoms have gotten more attention, both in diagnosis and as targets for treatment, it's actually the negative symptoms and the extent of the negative symptoms that look to be more predictive of actual patient outcomes. They're more correlated with how well the patients do than the positive symptoms are. And so it's useful to think about what we mean when we say negative symptoms. And there are, of course, several kinds. Blunted affect is one that gets noticed because it's often so obvious, the diminished range of expression that you see. But there are others. There's avolition, which essentially is apathy and withdrawal. There's asociality, a withdrawal from relationships and social interaction. Patients often express anhedonia, or lack of pleasure, or lack of anticipation of pleasure. And you can note alogia, They don't talk very much. Their speech is slowed down. They don't have a whole lot to say. And it's also useful to think of a couple of other attributes of negative symptoms. So first, how severe are they? Are they roughly as severe as the positive symptoms, and neither one is more prominent? Or are they more severe than the positive symptoms? Are they primary? Do we think they're part of the underlying pathophysiology of this patient's schizophrenia illness? Or are they related to some sort of comorbidity, either a psychiatric or medical comorbidity? And are they persistent? And do they interfere with the patient functioning even when you've treated the positive symptoms really well? And so this is something you see relatively commonly, is that you have positive symptoms under good control, but the negative symptoms persist and have a significant functional impact on the patient's life. There's a pretty broad differential for secondary negative symptoms. So obviously you can have primary negative symptoms that are a function of the schizophrenia illness itself, but when you're looking at negative symptoms as a secondary feature, they can be due to a number of different psychiatric conditions, things like dementia or depression or even substance use. If you have a stigmatized illness, as you do in schizophrenia, you're more likely to withdraw from social interaction. You don't really want to be out there if your illness is going to be something that brands you in a way that is unpleasant. If you are in pain all the time, or you never get a good night of sleep, that could leave you looking pretty tired and lethargic, and perhaps makes you look like you don't want to do anything. And unfortunately, even the medications we use to treat schizophrenia can cause a syndrome that looks like negative symptoms. You can have bradykinesia from antipsychotics that look like avolition or affective blunting, for example. So what do we know about the pathophysiology of negative symptoms? There's a lot going on here in this slide, but I'm going to summarize two key findings about what we think is the likely underlying circuitry. So the first is there appears to be a disruption in networks going from the frontal cortex to the temporal lobe, and decreases in gray matter in both of those regions. And this appears to be consistently related to negative symptoms. Second, there appears to be a disruption in corticostriatal networks, and this is strongly implicated in features such as amotivation, and anhedonia, and anticipatory anhedonia. In other words, believing that you're not going to get pleasure from an activity, and so of course you're less likely to engage in that activity. And so with this background in mind, let's talk a little bit about some of the therapeutic challenges we're going to see in our current treatments for schizophrenia. And to begin with, it's really important to recognize that over the years, our treatment goals have evolved. So in the 1950s and after that, when all we had was chlorpromazine and haloperidol, we were pretty focused on aggression and self-harm and positive symptoms, since that's pretty much all we could easily treat. Those were the things our medications were most effective for. And then when we started to have second-generation antipsychotics, we really started looking more closely at negative symptoms. The idea, the promise of second-generation antipsychotics was that they were going to be better for negative symptoms. But as you'll see later on in this talk, our actual success in treating negative symptoms with second-generation antipsychotics is pretty mixed. And so, of course, today we're starting to recognize that symptom control is just the beginning, that for true well-being, you have to think about functional status and quality of life and recovery, and that these are really core elements of the outcomes for our patients. And we're starting to pay more attention to a lot of these factors. So what do our current treatment options actually help with? Well, interestingly, this is from a 20-year-old article, but it's still basically true today. We've got first-generation antipsychotics. These are great for positive symptoms. They're not so good for negative symptoms or cognition. We've got second-generation antipsychotics, and these are also good for positive symptoms. And some, but not all of them, also have modest benefits for negative symptoms and for cognition. Advance the slide here. There we go. And of course, we use anticholinergics to treat movement-related side effects from our antipsychotic drugs. And these can actually be detrimental to cognition. And so we're left a little bit with this paradox where the symptoms we're best at treating are positive symptoms. But actual functional outcome is much more related to improvement in negative symptoms and to cognition. And so let's put some numbers to this when we're starting to think about how good our medications are. So this is a meta-analysis of over 160 randomized controlled trials with a total of over 28,000 patients. And they were looking at level of response to all of these antipsychotic drugs. And they had two basic metrics. The first was what they called any response. And this is basically, did you have a 20% reduction in your PANSS score or a CGI score of, quote, slightly improved? The second metric was good response. So they classified this as a 50% reduction in PANSS score and a CGI of much improved. And so what they found was that if you look at just any response, it's about half the patients. So about half the patients had some improvement, any response, slightly improved. But if what you were looking for was a good response, less than a quarter of the patients in this meta-analysis had what you classify as a good response. And even more troubling than that was that the effect size for negative symptoms was somewhat less, considerably less, than the effect size for positive and overall symptoms. Again, pointing to our actually quite good success in treating positive symptoms, but really very modest success in treating negative symptoms. And so what this really tells us is that efficacy and tolerability of a medication are obviously very important, but they're only going to be the beginning of the treatment. And that indeed medication has to be complemented by psychoeducation and psychotherapeutic interventions. And that this is especially important when you're thinking about building therapeutic alliance, which is crucial for medication adherence. And as we're going to see, medication adherence can be as important for the effectiveness of a medication regimen as the choice itself. Naturally, one thing that can significantly affect adherence is adverse effects. And this is an overview of the kinds of adverse effects that patients may struggle with. And before we get overwhelmed by the magnitude of what we're dealing with here, and before we overwhelm our patients, really important to note that many of these adverse events happen early, and if you manage them properly, are actually transient. So things like hypotension and anticholinergic effects and orthostasis and sedation, you can mitigate those by titrating more slowly. And if you do this correctly, patients will often develop tolerance to these adverse events, and they won't end up being that much of a long-term issue. Also, the acute and subacute motor effects, things like dystonia and akathisia, and even early Parkinsonism, can resolve if you reduce the dose or if you give patients adjunctive treatment. Now, this is obviously not true of all adverse events, and this is where things get a little bit more difficult. Tardive dyskinesia, of course, happens relatively late and doesn't always get better, although fortunately the risk is lower with our second-generation medications. And prolactin increases early on tend not to cause too many clinical issues, but longer term can result in pretty significant side effects. You can have sexual dysfunction and galactorrhea and infertility, an increased risk of osteoporosis and cancer, perhaps, and certainly antipsychotic-induced weight gain. Although it happens early in treatment, the problem is most patients don't lose that weight. So even though most of the weight gain happens relatively early, people tend to keep that weight on. In general, they're not going to lose it later on. And so that can have long-term metabolic consequences, things like diabetes and dyslipidemia. And so how badly do adverse effects lead to treatment non-adherence? Well, pretty significantly, it turns out. So this is a national survey of community-dwelling schizophrenia patients who are taking an antipsychotic. And the first really significant thing that stands out is that the vast majority of them, nearly 80%, reported at least one bothersome side effect. So not just one side effect, but one side effect that actually bothered them. And you can group the side effects into these 5 major clusters, things like EPS and agitation, metabolic effects, prolactin and endocrine, sedation, cognition, and GI. And what they found was that except for GI, all of the other clusters were associated with lower adherence to medications. Now, the EPS agitation cluster actually had the strongest effect, followed closely by the metabolic side effects. And this is especially notable because, as you all know, this is often a trade-off that we have to make as clinicians. We often choose a second-generation antipsychotic with lower EPS risk, but then we do face higher metabolic risk with that class of agents. The other really big finding here is that less than half of the patients in this study reported full adherence, and non-adherent patients had significantly higher rates of hospitalization and ER visits. So adverse events do indeed appear to lead to non-adherence, and non-adherence leads to fairly significant consequences. Now, interestingly, although EPS was associated with the highest rates of non-adherence, when you ask family members about which side effects most impact the quality of life of their relatives who are schizophrenia patients, they end up talking more about weight gain and sedation. Those end up being the most common answers. And EPS is certainly on the list, but it's less commonly identified than weight gain and sedation. And when you ask the patients themselves, the same thing is true. They also identify weight gain and somnolence as the main problems. And interestingly, they complain more of cognitive symptoms than they do of EPS. They talk about having trouble concentrating and losing their memory and feeling disorganized. And so there's kind of a clear trend here. Whether you're looking at the objective data or family members or patients themselves, weight gain and other metabolic issues appear to be at or near the top of the list. And so let's take a little bit closer look at that. And so to begin, it's really important to get a sense of the scope of the problem we're dealing with. So this is the global burden of disease study. It takes place every 10 years or so. And what it finds is that mental and behavioral disorders are still one of the leading cause of years lived with disability. So what they do is look at how many years each of these different conditions leads to a patient living with disability. And you can look at a slightly different metric, which is disability-adjusted life years. This is essentially years lived with disability plus reduced lifespan due to whatever illness or condition you're looking at. And here you can see the profound impact of cardiovascular and circulatory diseases. Now, of course, we know that cardiovascular and circulatory diseases and metabolic issues are more prevalent even at baseline in people with schizophrenia. And of course, we know that we contribute to this with use of antipsychotic medication. So with this background, let's go back and take a look at the patient we introduced earlier. So remember, this was a 21-year-old male with a diagnosis of schizophrenia, had positive symptoms under fairly well control, but still had negative symptoms. So following this patient's diagnosis, he had multiple failed medication trials. He was tried on aripiprazole, but had some akathisia, was tried on lorazepam, which wasn't particularly effective, was tried on risperidone, which was partially effective, but had significant prolactin elevation that did lead to adverse events, including gynecomastia, which he found fairly distressful. And so for the last 6 months, this patient's been on Olanzapine. And on this, he does report that hallucinations and delusions are significantly improved. But he still has negative symptoms, as we previously described. And he's unfortunately had a 30-pound weight gain. And his labs show an increase in LDL and triglycerides. So how do we interpret these responses to medications and the resulting adverse events? So this chart is based on a narrative summary of common adverse events that are reported in the literature with different antipsychotics. And there's a lot going on here and a lot of different side effects that are listed. And so we're going to focus particularly on weight gain and metabolic issues because that's a key topic that we're covering here. First thing to point out is that there's a lot of variability between the different antipsychotics on this list in the level of weight gain and metabolic syndrome. So you can see the indicators of 0 or a single positive, and that means it's actually relatively low prevalence with that antipsychotic, going all the way up to 3 pluses, which means that it happens at a fairly high rate. And you can see fairly immediately that of all of the second generation antipsychotics that we use, clozapine and olanzapine clearly appear to have the most impact in this area. And so here's a more detailed look at this. This is a network meta-analysis looking at metabolic effects with 18 different antipsychotics. As you glance at the list, you might note that you don't recognize some of these if you're from the United States. This was published in Lancet, it's international, and they looked at antipsychotics from all over the world, not just the ones we have here. And when you look at the data in this way, it becomes clear that there is a difference in risk between different agents. So you can look up at the top for the lower risk agents. Those tend to be things like the partial agonists like aripiprazole and cariprazine and brexpiprazole, agents like lorazepam and zarpazodone, and even our high and mid-potency first-generation drugs, things like haloperidol and fluphenazine. And then all the way at the bottom, you can see our highest risk agents, clozapine and olanzapine. So here's the problem. In this same analysis, they also found that the most effective medications we have clearly appear to be clozapine and then to somewhat lesser degree, olanzapine. And so that's really the dilemma that we're left with and the dilemma that our patients are left with. The patients and their family members and our objective data identify metabolic issues as the adverse event that perhaps most affects patient quality of life. These metabolic issues are clearly associated with non-adherence, and so our best practice is probably to start with agents that have lower metabolic risk. But then some patients don't respond to these agents that have lower metabolic risk, and they end up requiring something like olanzapine or clozapine in order to actually treat their symptoms. And then predictably, many of them will develop the metabolic issues associated with these drugs. And so we're left with the question, what do you do? Now, the answer to that is a little bit beyond my pay grade, but it's well within Dr. Carell's pay grade. So I'm going to hand it off to him for the second half of this talk.
Excellent. Thank you so much, Sanjay. This was an outstanding job, how you put all of this together and brought it to life, going into detail, but also giving the broader picture and weaving it together with the clinical case. So I hope all of you watching and listening enjoyed it as much as I did. So I'll pick up from here and talk about some of the agents that we summarized in a recent paper, and also going a little bit further in the direction of what are our safest agents, and one of the newest approved agents is very safe. And then how can we make maybe olanzapine, which is a higher risk agent, a little bit safer, which is another new agent that is most likely going to be approved this year. So let me start with the latest addition to our antipsychotic armamentarium, Lumateperone, approved for the treatment of schizophrenia December 20 last year, and actually since yesterday having had the second positive trial in bipolar depression, for which it is also being studied. So that will be submitted to the FDA also. What's different about Lumateperone? Do we need another D2 me-too antipsychotic? And actually it is not a D2 me-too antipsychotic because, for one, it has the highest affinity for 5-HT2A relative to D2, 60-fold more affinity, so it's very potent. What does that mean? Well, it means that there's a very low likelihood of extrapyramidal side effects, but there's a second reason for that also, pharmacologically, I'll talk about in a minute. But initially, when Paul Janssen created risperidone, he added 5-HT2A antagonism to haloperidol, creating risperidone, because for clozapine, the tighter binding than dopamine was for 5-HT2A. And then after a while, we thought, well, maybe it's not that much important for efficacy, it's more important for safety. But another agent I'll be talking about a little down the road, Pimavanserin, which is approved for Parkinson's psychosis and has positive data for psychosis associated with dementia, is a 5-HT2A inverse agonist and has some data suggestive of increased efficacy when added to other antipsychotics. And we'll talk about that. So it seems that 5-HT2A blockade may have both an advantageous effect on reducing EPS, but also adding maybe some efficacy. Now, on the other hand, what's different about D2 with Lumateperone? Lumateperone seems to be the only drug at the moment available that has a dissociation between the pre- and postsynaptic activity on the D2 receptor. All other antipsychotics are either full antagonist postsynaptically and presynaptically, or partial agonist pre and post. Why is that relevant? Well, if we block postsynaptic dopamine receptors, that's maybe what we want, but that's the gas pedal that we block. But if you also block the brake, the presynaptic receptor, you're releasing more dopamine. So basically, there's a catching up between over-release and blocking until we have maybe to block 60 to 80% of dopamine receptors to have an equilibrium. Whereas if you have a partial agonist pre and postsynaptically, you're stimulating the brake, but you're also stimulating a little bit postsynaptically. So you need to actually occupy 90 or 95% of dopamine receptors to get the right balance. Now, lumateperone is a presynaptic partial agonist, only presynaptically. So it stimulates the brake, thereby reducing the transmission of dopamine and the postsynaptic effect, requiring only 40% of postsynaptic blockade. It's actually very little postsynaptic blocking like clozapine, which predicts very low prolactin elevation, very low EPS and akathisia. Actually, prolactin, EPS, and akathisia were at placebo levels because of this dissociation of partial agonism pre and full antagonism post, only requiring 40%. Interestingly, it has an inbuilt serotonin reuptake inhibition mechanism at the same strength as the D2 antagonism. And as I just mentioned, the second trial on bipolar depression was positive, which most likely has also to do with that mechanism. D1 is in the close proximity of the affinity for D2, and there is data looking at animals that the D1 associated effect may actually translate into NMDA, glutamatergic NMDA, and AMPA increase. So that makes this agent in the future also interesting for maybe improving negative symptoms or cognition. On the other hand, very low affinity for the side effect receptors that we don't want, histaminergic and muscarinic effects. It is metabolized mostly by 3A4. Cytochrome P450 was a big road in the liver, so also less pharmacogenetic variability. So you need a lot of blockade of that enzyme to increase or decrease its, or blocking the enzyme to change the level. It has a slight unique metabolism on the UDP, that's the glucuronidyltransferase enzyme, and that is also used to break down valproic acid. So if you co-treat with valproic acid, some of the levels of lumateperone might be increased. The effective half-life is 18 hours. You can give it once a day, and currently there's one starting and effective dose, 42 milligrams once a day, no titration needed for this medication. What are the data? This was the first trial where lumateperone in blue was compared against placebo in gray. A higher dose was also, no, that's wrong. So the dark blue is the 42 milligrams of lumateperone. The light blue was actually 84, which did not work versus placebo. It's interesting, maybe because it's a partial agonist pre and a full antagonist postsynaptically, you need to get a sweet spot. Nobody knows, but you can see that the assay sensitivity, risperidone 4 milligrams, actually had the same, very similar efficacy on total PANSS and on positive PANSS like lumateperone 42 milligrams. What about additional outcomes? This is the phase 3 study where again 42 milligrams were studied. This is again in the dark blue against placebo in gray. And here efficacy as early as week 1 and sustained out to week 4 for lumateperone against placebo on 42 milligrams. The 28 milligram dose that is not approved did not make it on total PANSS, but it was significantly better, like the 42 milligrams, on total positive subscale symptoms and on clinical global impression scale. So we've seen that more and more that those agents that are very safe don't have any more side effects than placebo, except for 2, which I will talk about in a minute. It's harder to separate on total PANSS because you have so many other symptoms that you can hit with side effect receptors. It's a pretty clean antipsychotic. But approval because of these 2 studies for Lumateperone, 42 milligrams. Now, as you know, in randomized controlled trials, we have a pretty strong selection to patients that are willing to engage in the randomized double-blind study, and they're all inpatients, to look at the cardiometabolic safety that in the short-term trials was like placebo. A switch study was done where patients came from the usual antipsychotics that we give nowadays, risperidone, quetiapine, aripiprazole, and olanzapine were the four big ones. And when they were switched to lumateperone, after just 6 weeks, there were already statistically significant improvements, just 6 weeks after switching, in LDL cholesterol, total cholesterol, as well as insulin and weight. So we have here a medication that was able to keep patients stable. They were stable to begin with, no worsening overall, actually a slight improvement that was even statistically significant, but it's an open label study. But still, there was a significant improvement in key cardiometabolic parameters. Interestingly, just 2 weeks after switching back to a prior antipsychotics, 80% went to the exact same antipsychotic. These gains were lost. So we may have an agent here that can actually keep people stable, but really benefit long-term cardiometabolic health. Now, this is 6 weeks. What about going for a year? And here in the interim analysis of the 1-year study, significant improvement, again, in total cholesterol, LDL cholesterol, which is the key parameter for cardiovascular risk and coronary artery risk reduction, as well as prolactin reduction. At the same time, on the right-hand side, there was an decrease in total PANS. So here we have patients who are remaining stable but improve their cardiovascular health. And there was also a statistically significant drop in weight. There was actually 7 pounds at 1 year in those patients that made it to 1 year. What about safety issues? Those that had at least 5% of patients with safety concerns and double the rate of placebo. There were only 2, somnolence and sedation, 24% versus 10% on placebo, but this was morning dosing to really see what happens at the peak level of the medication. In the switch studies, lumateperone was given in the evening, and here the sedation rate was around 9%. The other side effect, dry mouth, also made the cut of at least 5% and double the rate of placebo. There were placebo level effects on EPS, akathisia, weight gain, metabolic parameters, and prolactin levels. So at the moment, most likely the safest antipsychotic that has made it to market. The other agent that is most likely coming to market, there will be a hearing by the FDA to see whether that is true, is a modification of olanzapine. Sanjay actually mentioned that in some analyses, olanzapine and clozapine seem to come up on top for efficacy for short-term and some long-term outcomes. Most likely the side effect differences are larger than the efficacy differences, but still there may be patients that really particularly respond to olanzapine. But as you know, its Achilles heel is the severe weight gain and also the related metabolic problems. So what Alkermes has been trying to do is to make olanzapine great again, giving it a better profile in terms of safety while maintaining its efficacy. So the first study that was done as a phase 2 study looked at patients who had a 1-week lead-in period of olanzapine. And in the total group, you can see that it took some time, it was a smaller study, for the olanzapine samidorphan, which is a mu opioid antagonist, blocking some of the pleasure we may get from food intake. I had a significant decrease in weight increase versus olanzapine, which was the dark blue line on the left-hand side. And what's interesting is that there's apparently a delay in the onset that takes about 5 to 6 weeks, but after that, the line is flat. So it basically doesn't seem to cause any big weight gain anymore. And When you look at the people who had at least some weight gain in the first week, so they had more room for weight gain, this line for olanzapine samidorphan is exactly the same, but the olanzapine patients gain even more weight. So the separation is greater. Once you switch people from olanzapine to olanzapine samidorphan, or continue people on the olanzapine samidorphan combination, there is this flat line. Again, there doesn't seem to be further increase in body weight, although with olanzapine, what we've seen, that there is a weight gain that continues for 12 to 18 months. Now, the FDA said, based on these data, you have to do 2 studies to maybe fulfill the approvability of this drug. One, you have to tell us, even though there's a CNS active drug that you're adding, the mu-opioid antagonist, what does it mean for efficacy? Does it detract from olanzapine's efficacy? So this was a 4-week study in acutely exacerbated patients. Quite a high placebo effect, 17 points. That's what we usually get with antipsychotics. But despite that, olanzapine proper and olanzapine plus ALKS plus samidorphan basically held its own and was significantly better. So checkbox 1, the combination is not inferior in efficacy. Numerically, it was at least as good as olanzapine alone. But then the second point was, well, give me a larger study and show me not at 12 weeks, but at 6 months that there is a cardiometabolic advantage. So here, the co-primary outcomes were actually change in, in body weight, percent change in body weight per visit. And you can see here in this larger study that again, there's a delay for 4 to 5 weeks where there is weight gain, but then it seems to almost flatten out. Whereas with olanzapine alone, there is more weight gain, and that was statistically significant. If you look at the overall distribution, there's a shift to the left that overall patients gain less weight in each of the categories. The co-primary outcome categorically was at least 10% body weight gain, which is the first line to the right, which was statistically and clinically relevant, different from olanzapine. And the other one, the key secondary outcome, was at least 7%. Now, we've seen that it takes about 6 weeks to separate for the weight to become significantly better with the combination of olanzapine and samidorphan versus olanzapine, but actually on waist circumference, which is maybe a marker of adiposity, central adiposity that has some metabolic importance, the difference was actually seen at 4 weeks and was already statistically significant. Looking at the outcomes in a table, you can see that there's basically almost a reduction by 50% or more, 57% less weight gain, looking at percent weight gain, and actually an odds ratio of 0.5, cutting the risk of at least 7 or 10% weight gain in half, with a number needed to treat of 9 and 7 respectively. There was also weight gain, 3 kilograms with olanzapine, samidorphan, but clearly different than the 5 kilograms with olanzapine. And in this paper that just came out in the American Journal of Psychiatry, we argued that this is most likely a conservative difference because we found less weight gain with olanzapine over 6 months than expected. And why was that? Because we capped the baseline BMI at 25, thinking there's more room for weight gain, although currently in the US, there's basically the mean BMI is 30. And what we may have done is selected a subgroup of patients that were metabolic survivors. Despite 10, 15 years of illness, they actually did not get to 30, 35, and 40 BMI. And therefore, we may have actually capped, different from what we thought, the weight gain. In this study, there was a peculiar finding that olanzapine samidorphan did not show superiority in metabolic outcomes versus olanzapine, but olanzapine also did not show much in terms of metabolic worsening over 6 months. Again, maybe playing into the issue that we may have selected a metabolically more resilient group. And a currently ongoing study, the ENLIGHTEN-Early, that looks at people with a restricted prior exposure to antipsychotics, will hopefully show more what the weight and the metabolic advantages of this combination treatments are currently evaluated by the FDA. And as far as the data stands, the 2 checkboxes of the phase 3 trials were performed with statistically and clinically meaningful results. So we'll see whether this will be our next approved and improved Olanzapine. Side effects, basically the same as Olanzapine. There is no difference looking at these 2 agents. It is Olanzapine, but it has less weight gain. That is its main difference. Now, let's come to a very exciting moment in psychiatry where we have maybe 2 novel mechanisms of action, and actually there's a third that we didn't include in this here, which is using a muscarinic agonist, M1, M4 agonist, xanomeline, which is centrally active, and pairing this with a only peripherally antagonizing cholinergic drug that isolates the central activity. So that's CAR-XT, the xanomeline plus trospium, which we don't discuss here, but that's another new mechanism that may be related to clozapine, because clozapine is the only drug that causes some hypersalivation, which is a pro-muscarinic effect. But the other really new mechanism of action would be a TAR1 agonist. Now, what does TAR1 stand for? That is a trace amine associated receptor 1 agonist. These are intracellular receptors that are quite nifty because they A, reduce the uptake of dopamine into the presynaptic terminal, and B, reduce the firing out of the presynaptic terminal to release dopamine. We think that the pathophysiology of schizophrenia mainly resides in the presynaptic overproduction of dopamine. There's much less evidence that there's a postsynaptic problem. So this may become our first presynaptic drug that really recalibrates the over-excitability of dopamine, of the dopamine system presynaptically. At the same time, there's an added benefit that a TAR1 agonist can also work at the appetite and satiety center, reducing appetite, and it sits also in the liver, reducing glucose levels, and in the pancreas, increasing insulin production, actually all acting in concert to improving insulin resistance and glucose intolerance, even without any modification in weight. Now, this all has to pan out clinically, but that's obviously something quite exciting. What does it mean in patients with schizophrenia? Well, whenever a study makes it that is psychiatric in nature into the New England Journal of Medicine, the most impact factor laden one that is not like a cancer journal, then it means everybody, the reviewers and the editors, think this is really big news beyond psychiatry. The medical specialty needs to know about it. And here what was shown was that SEP856, which is the short for Sunobion's TAR1 agonist under development right now, was significantly better in a 4-week study than placebo on the key primary outcome, which was total PANSS, with an effect size of 0.45, that is on the higher end of the currently approved or recently approved agents. And it was also effective for the Clinical Global Impression Severity Scale. And it was more effective than placebo, and here with an effect size of 0.5, even higher, for global efficacy, but also for positive as well as negative symptoms. Now, Dr. Rao already mentioned that some of the negative symptom improvement in acute studies may be due to an improvement in positive symptoms. So we don't know whether a TAR1 agonist would have some primary efficacy for negative symptoms. That would have to be studied separately, but at least these data suggest that in the trials done, that a TAR1 agonist, SEP856, was statistically and also clinically meaningfully better than placebo. There are many studies now ongoing to replicate this in several different populations, and we hope that this could become the first non-postsynaptic dopamine receptor modulating drug. that still works most likely on the dopamine transmission, but in a very different mechanism, going into the presynaptic side of things, where we believe the pathophysiology of schizophrenia or psychosis resides much more. What about safety? It was well tolerated. Somnolence, the most frequently observed side effect, only 7% versus 5%. All other adverse effects were below 5%. And that included also the key topic of our discussion today, cardiometabolic side effects. No difference in weight, no difference in metabolics, like lumateperone from placebo. And also, since it's not a postsynaptic dopamine blocker, not a drug that modifies that transmission on the site postsynaptically, EPS, akathisia, dyskinesia, all not different from placebo. So quite exciting. And the last exciting drug goes back to the 5-HT2A modulation that we want to reduce its tone. Now, all atypical antipsychotics have some 5-HT2A antagonism, but antagonism means you silence the receptor. You're just sitting there and you don't let the endogenous serotonin go to this receptor and have downstream effects. What an inverse agonist does, it actually puts the gear in reverse. So it is even stronger. So for example, an antihistamine is an inverse histamine agonist. That's important when you have someone who has a shock symptom, because here you want to have not just no further shock, but you want to reduce or invert that. So what you can see here is that Pimavanserin approved already for Parkinson's disease psychosis. So when you give extra or iatrogenic dopamine, it can reverse the psychosis, and it also has data for Parkinson's psychosis. When you give that is also a 5-HT2C antagonist, that there is an effect on negative symptoms and somewhat on positive. And we'll talk about that in a minute. There are no direct actions on dopamine, adrenergic, histamine, serotonin, or other cholinergic receptors. Again, metabolized by CYP3A4. Half-life is quite long, steady state at 12 days. The 34 milligram dose is approved for Parkinson's disease. And with renal impairment, you might want to actually see whether there could be a lower dose. Now, this was the negative symptom study. Usual design, you have a screening and lead-in period where there might be actually some befriending and you get some improvement in negative symptoms, but you only take the new baseline and people who haven't improved too much. And then there's a double-blind portion where the background antipsychotic is continued, that had to be stable before, and either Pimavanserin, double-blindly added, or placebo. Treatment for 26 weeks, and these are patients with predominant negative symptoms. Remember what Dr. Rao mentioned, this is important for negative symptom studies, that we don't confound via pseudo-specificity some negative symptom improvement simply because patients improve in their positive symptoms. So these patients had relatively little positive symptoms, but strong negative symptoms. Patients also couldn't have depression, because if you improve depression, that would also be a pseudo-specific effect on negative symptoms. And EPS was also an exclusion criterion. Here, the primary outcome was not the PANSS negative symptoms factor score, but the NSA 16, which has not 7, but 16 items for negative symptoms, which makes sense because we want to be more specific. And the key secondary outcome was the PSP, the Personal and Social Performance Scale. You could start at 20 milligrams, go up to 34, or if needed, go down to 10 for the first 8 weeks, and then patients had to be on the stable dose for the remainder of the trial. As I mentioned, predominantly negative symptoms with at least 2 items, moderately severe, and very little positive items. And basically only 2 out of 3 items had to be no more than moderate on the delusion, hallucination, or suspiciousness. And the CGI severity score for negative symptoms assured that on a clinical global rating, there was at least moderate illness severity. Exclusion criteria were too much akathisia, EPS, the CDSS is the depression scale, and also very little positive symptoms. So very nicely designed. And here are the results for the overall group, taking all those groups together. Statistically significant finding at week 4, as well as week 20 and 24. But as you can see, the effect size, which is the standard deviation portion difference between drug and placebo, was on the small side, 0.2. So would we really think that overall this is strong enough? Maybe, maybe not. But there is a subgroup analysis looking at the higher dose, the 34 milligrams that are actually approved for Parkinson's psychosis. And here you can see there was a 50% greater effect size, 0.34. And this is actually the drug the company is carrying forward into phase 3. Question mark for me is, could it even be a higher dose? But interestingly, the lower dose, the 20 milligrams, didn't separate from placebo at all. Now, what is not on the slides is a study on residual positive symptoms where overall Pimavanserin did not separate from placebo, but in the 80% sample that was studied in Europe, that was a pre-specified analysis, actually there, even attenuated positive symptoms improved with the addition of a 5-HT2A inverse agonist. So there may be something to look out for in the future, whether this could both treat residual negative as well as positive symptoms. But again, the primary outcome was negative. Now, let me finish up with the real-world strategies. So go back to our case of the 20-year-old male with diagnosis of schizophrenia. The pharmacologic options for this patient led to, unfortunately, multiple failures due to lack of efficacy or adverse effects, including the ones that we're very well used to, and that is EPS or akathisia, prolactin elevation, but also metabolic dysfunction and relatively little effect on negative symptoms. So the question then arises, well, if our current armamentarium may not help with the efficacy enough or has too many side effects, what could be some of the non-pharmacologic interventions, and how effective would they be for both efficacy and safety parameters? Well, we know that CBT can somewhat help the positive symptoms as well as adherence therapy. We also realize that psychoeducation is important. But for side effects, we have basically lifestyle instruction and lifestyle change or modifying behaviors treatments. So I would say that first we should try to do no harm, as Sanjay already mentioned. So at the initiation of an antipsychotic, do healthy lifestyle counseling. What does work, what doesn't work so well. Apparently my lighting is getting a little off here. Sorry about that. And then after this has occurred, we would do also starting with a lower risk antipsychotic as much as possible. After that has occurred, and if there are still side effects, you might want to increase level 1, but also you could switch to a lower risk antipsychotic if that were positively possible. But then if there are still side effects, what may have to happen is actually engaging our primary care or internal medicine colleagues in order to treat the hypertension, the diabetes, or the dyslipidemia. Obviously, prevention is the main goal. So starting with low-risk agents would be far superior and the choice we should take. Now, when switching to lower-risk agents, which could be the partial agonists, ABC, aripiprazole, brexpiprazole, or cariprazine, but also the very safe, most recently approved Lumateperone, we want to do a plateau cross-titration if we're coming from more tightly binding agents that when they are released from that receptor can cause rebound phenomena. And these rebound phenomena could be due to a tighter histaminergic or cholinergic blockade, like with the penes, where you add on lumateperone, 42 milligrams, starting dose is the working dose, wait for a week, and then in 2 or 3 steps, bring down the first antipsychotic. Since lumateperone has so few side effects, the overlap should not be a problem. But also, coming from the domes that have very tight D2 binding postsynaptically, there will be an upregulation. And since lumateperone doesn't block more than 40% of postsynaptic receptors, it doesn't have to, there could be, again, a rebound that the endogenous dopamine hits upregulated, overexpressed dopamine receptors. That's why the plateau cross titration is definitely what we would recommend. What about strategies to reduce cardiometabolic burden? In this case, let's focus on weight gain. This is from an umbrella review that we published in World Psychiatry last year, looking at different strategies. On top, not circled, you can see that non-pharmacologic treatment options actually have a large to medium effect size. Individual lifestyle counseling, exercise intervention, and psychoeducation. But be aware that this is much more efficacious in the subgroup of patients who are willing to engage in a randomized controlled trial and who say, yes, I want to be here and I'm motivated to do this. In many of our patients in real-world clinics, it's much harder to get such a good outcome. What about some of the other strategies that are pharmacologic? Adding aripiprazole to either clozapine or olanzapine, but only those high-risk agents, could potentially benefit patients in terms of weight loss. But then metformin and topiramate have the best data currently, followed by GLP-1 receptor agonists, which are new treatments for diabetes. So liraglutide and semaglutide are two of those, but unfortunately they're only available as injections, either daily or weekly, but oral treatments are being pursued. Many other treatments are not helpful, and so at the moment I think we're stuck with either low-risk agents to begin with or a switch, or going to metformin or to topiramate. So let me finish up with our blueprint paper published in Lancet Psychiatry last year. A large group of investigators put their collective wisdom together, and there are issues and actions. Obviously, to improve physical health, we need mental health, but also to improve mental health, we need physical health. We need to add life to years and not just years to life. Therefore, we can't just give treatments without considering side effects, and particularly physical health needs to be addressed. So elevated smoking and other poor healthy lifestyle behaviors need to be identified and addressed. Prescribing needs to be optimized in the sense that we use lower risk agents first as much as possible to get all of the responders that we can before graduating to higher side effect laden drugs. We should also measure and monitor and address side effects as they occur. And also we need to do health promotion and also destigmatization via campaigns, and obviously provide integrated care rather than fragmented care. The proposed model involves also strengthening our collaborations between psychiatric and medical colleagues, and also involving patients, families, and empowering them. So to summarize and give us ample time for discussion, schizophrenia remains an illness that is still all too often chronic and relapsing, unfortunately associated with poor psychosocial and functional outcomes. Symptom domains beyond positive symptoms clearly need to be addressed urgently. We've heard about this from Dr. Rao in his first presentation. Also, adverse effects, we heard from him, can undermine treatment success, reducing both physical health, quality of life, and adherence. And the top items reducing quality of life were weight gain, sedation, and some cognitive disability that came about through either sedation or also EPS. And obviously the big problem with adherence were all cardiometabolic side effects, but also agitation, EPS, and akathisia. So adverse effects need to be monitored and addressed, and we need to reduce cardiometabolic burden in order to not just treat symptoms, but the whole patient, and giving people more years to live a healthy and productive life. Recent FDA approval has come for Lumateperone, which is a novel antipsychotic modulator that addresses both dopamine, serotonin, and via D1 some glutamatergic transmission. Seems to be very safe, very little side effects beyond dry mouth and sedation. FDA evaluation currently for ALKS 3831, that's olanzapine with the mu opioid antagonist samidorphan, which causes clearly less weight gain and also less adiposity or waist circumference than olanzapine alone, with further investigation into the metabolic differences. And there were encouraging phase 2 results for the TAR1 trace amine-associated receptor 1 agonist SEP856 for total psychotic symptoms, but also with good efficacy for negative symptoms and clinical global impression scale severity. And the adjunctive inverse 5-HT2A agonist Pimavanserin was effective in a phase 2 study for negative symptoms. And as I mentioned, the M1, M4 muscarinic agonist CARXT, which is xanomeline plus trospium, the extra cerebral anticholinergic drug, also had positive effects for psychotic symptoms. What we need are novel mechanism actions for schizophrenia that address more than just positive symptoms or that address residual positive symptoms, but we also need to have medications that are safe and not cardiometabolically problematic. This has been shown for Lumateperone, for SEP856 and Pimavanserin, and ALKS 3831 is a safer alternative to olanzapine without impairing olanzapine's efficacy. So that concludes our formal presentation. We're really grateful for your attention. Hope that the content was really helpful for your clinical work and look forward to many questions that Sanjay and I can answer. Thank you very much for your attention.
Thank you so much. Dr. Correll, Dr. Rao, that was such a whirlwind presentation, and we all thoroughly enjoyed it. So before we get to your questions for our dear audience, please be sure to take a moment to answer the polling questions again that you should see on your screen. So now let's get to the first questions, and these are the most voted questions that we received, and we'll go from the most popular in that order. So the first question that we have is, the worst problem in our clinic is patients using methamphetamines, even when taking long-acting injectables. What can you suggest to address this issue?
Well, I'll take a stab at this one. So, I work on a VA inpatient unit and sometimes in the emergency room as well. And so I'm very familiar with this patient population of high methamphetamine use in the context of using antipsychotics. At the end of the day, one of the things I tell patients is, look, your drugs are stronger than my drugs, right? I can try to help, but you can probably overwhelm whatever it is I'm giving you. Now, that being said, I really like that the question was framed with the idea of using a long-acting injectable, because we pretty much know that if you're using methamphetamines, you're probably not stopping to take your antipsychotic. So at least if you're on a long-acting injectable, that can provide some protection. I think there is a case to be made for using a particular type of long-acting injectable when you're a chronic meth user, and that's that you probably want to be on a high-potency D2 blocker versus something like a partial agonist. I don't remember the precise paper, and Christoph maybe has this off the top of his head, but there was something a while back looking at relapse rates on methamphetamine when you were on an agent like aripiprazole versus on a full D2 blocker like risperidone or Haldol. And the relapse rates and the hospitalizations were a little bit lower when you were on a full D2 antagonist compared to when you were on a partial agonist. So our kind of go-to is that we're going to use a strong D2 blocker LAI in patients with methamphetamine dependence. But again, just cautioning them that they can probably overwhelm that still, but at least it'll still be there in the background.
Yeah, Sanjay, I totally agree with what you've just said. We actually have become quite interested in the phenomenon of BAMM, B-A-M-M, which is breakthrough on antipsychotic maintenance treatment. And we used exactly the LAI paradigm and found that between 15 and 25% could break through antipsychotic treatment that is assured. And the main driver was substance abuse. So as you mentioned, overriding the doping blockade, which would maybe mean that we should go a little bit higher on the dose. Because there is this intermittent dopamine surge that patients get. So even, obviously you don't want to go above the neuroleptic threshold that they have EPS or akathisia and it's uncomfortable. But if you're already on the highest dose, maybe you want to shorten the injection interval to at least have enough blockade in there when people add fire to the oven.
Excellent strategies. The second question that our audience wanted to ask was, can you address treatment-resistant psychosis? Treatment-resistant psychosis that occurs even with Clozaril.
Well, I'm not entirely sure. I think I think I understand what you mean. So there's obviously treatment-resistant psychosis, but there's also clozapine-resistant psychosis, which we could say are two subtypes. So yes, this is a huge issue. Now, for resistant schizophrenia to first-line agents, clozapine is the name of the game. That's the best studied drug. It, in a meta-analysis by Dan Siskin, showed that 40% of those patients that did not respond to first and second line agents actually would respond to clozapine. So again, 6 out of 10 may not. And then ECT, electroconvulsive therapy, is the next best treatment that we would recommend. Now, we did a meta-analysis in World Psychiatry of augmentation strategies for monotherapy with an antipsychotic, both non-clozapine and clozapine, and found several agents to potentially be helpful, but the quality of the meta-analysis was great, yet the quality of the studies was not so great. And since most clinicians, when they do polypharmacy, would use a second antipsychotic, we look particularly also at 2 antipsychotics versus 1. And in our meta-analysis, yes, 2 were better than 1, but only in open label studies. When everybody knew, oh, I'm getting a second one, I will be doing better. The rater knew, the patient knew. However, in real world samples done in Sweden by Jari Tihonen, actually out of the 10 best treatments to prevent readmission in schizophrenia, 8 were long-acting injectables, but the 2 monotherapies that held their own were, sorry, not mono, the 2 oral treatments were clozapine and antipsychotic polypharmacy. We followed then up with a polypharmacy paper and looked at polypharmacy versus monotherapy and found that 8 of the 10 best treatments to prevent hospitalization were actually 2 antipsychotics together, and only 2 monotherapies held their own, and that was clozapine and the LAI. But when you looked at the combination treatments that were more efficacious, it was mostly a combination with either olanzapine or a long-acting injectable. So I would say if you have someone who's resistant, rule out pseudo-resistance, i.e. give them and we published this in our TRIP guidelines, the treatment resistance and relapse guidelines in the American Journal. Oliver House is the first author. I and John Kane are the shared last authors. We said, please, to rule out pseudo-resistance where somebody's not taking the medication as prescribed, try at least 1 time a long-acting injectable. And then if that doesn't work, obviously you have to go to clozapine, or as I just mentioned, maybe a combination of an LAI with an oral treatment or clozapine with another oral treatment would be a potential option. But what we need are novel mechanism action drugs that could go beyond what we currently have to treat those patients that may have a different pathophysiology, maybe not so much dopamine, which some imaging studies suggest, but rather more glutamatergic type of psychosis.
Got it. And just for our audience, just in case they missed it, I think you said one key thing, the TRIP guidelines. Could you repeat that acronym and the first author again?
Yeah, it's the treatment response and relapse guidelines in psychosis. And Oliver House, Howes, is the first author, and that was the American Journal of Psychiatry, I think 2017.
2017. Got it. Thank you so much.
TRRRP.
Got it. And the next question that we have from our audience, they asks, what about upcoming long-acting injectables? And you just mentioned how important long-acting injectables can be for treatment-resistant psychosis. Are there any upcoming long-acting injectables on the horizon?
Do you want me to take that, Sanjay?
Sure, yeah.
Yeah, okay. So basically, first of all, we have seen a novum in long-acting injectable treatments, two of them, I think. One was, it's a little older already, that we were able to get now an injection interval beyond just 4 weeks into 3 months with paliperidone palmitate. And the next innovation was to go from deep intramuscular injection to subcutaneous injections with Perseris, which is once monthly risperidone, which also doesn't need any co-treatment orally. What are the current innovations? There is another subcutaneous antipsychotic that Teva is developing, that's TV46000, which is also given at 2 different doses and doesn't require oral co-treatment. So we're expecting this to read out maybe in the next 4 to 6 months. Then in Europe, Rovi developed another once monthly risperidone that actually has therapeutic drug levels within 48 to 36 hours, doesn't require oral co-treatment, but that's not subcutaneous like the Teva drug, it is intramuscular. And then Janssen is developing beyond the 3 monthly, now the 6 monthly paliperidone, which could be another option to really extend the care, and then you would have only to give this medication twice a year. Obviously, at the time of the pandemic, to extend the injection and the need to come in beyond 2 or 4 weeks is already, I think, something we should all consider.
Thank you so much. And that's phenomenal. Every 6 months, that's just twice a year. So the next question that we have from our audience is, quote, I am treating a patient whom with any and all atypical agents prescribed, they experience moderate to severe extrapyramidal symptoms, akathisia, muscle tightness in the legs, and the only medicine that helps is Cogentin, or benztropine, 3 milligrams daily. The question here is, I am concerned regarding the long-term use of anticholinergics due to risk of dementia. Would you comment on any treatment options that you'd go to for this moderate severe EPS?
Well, so it's interesting, without having a little bit more detail and not knowing which specific agents are being used and what doses they're being used at, I'm going to make a couple of assumptions that if they're struggling with this with every agent, they're probably not trying really high doses, but are seeing these effects even at modest doses. This may be someone who it would be a good idea to get, for example, genetic testing on to see if perhaps they are slow metabolizers at multiple sites and therefore are having kind of outsized effects with even low antipsychotic doses. What we don't know from the question is, are they giving modest doses that are causing lots of EPS and still don't have efficacy? So what's kind of, what's their balance of efficacy versus EPS? Could it be that if this patient's a very poor metabolizer, they can get away with lower doses that would then cause less EPS and have less need for chronic antimuscarinic agents, which I agree would not be great long-term. And in fact, we talked about this in the talk itself, that chronic use of antimuscarinic agents can certainly lead to very undesirable long-term effects, even short-term effects, right? I mean, if you're getting benztropine all the time, you're at higher risk for urinary retention and constipation. And if the patient's older, you might be at higher risk then for delirium and other things. And so that might be one thing I would look at for someone who seems to keep getting side effects on everything, no matter what. And then, have they tried clozapine, right? Have they tried something that has almost no EPS?
Yeah, picking up from that, I think you're hitting it on the nail. In all meta-analyses, the only drug that had even less EPS than placebo was clozapine. So there shouldn't be EPS, but there can be akathisia with clozapine. But the other two agents that have low postsynaptic binding would be quetiapine, as well as now lumateperone, where we would not expect EPS at effective doses or akathisia. So those should be tried. If they have been tried, then I think clozapine would be an option. And then in the meta-analysis looking at benzodiazepine, it's an old meta-analysis, benzodiazepine augmentation of antipsychotics for efficacy that didn't work. The one thing where it was significantly better than placebo was on less EPS. We can treat EPS also with a benzo. Now, do we want to have long-term benzo use for EPS? Most likely not. So I guess I would try quetiapine, lumateperone, or clozapine to not have the cogentin long term, which can reduce cognition. And as we've recently seen in a paper in neurology, actually may predispose to people having a minimal cognitive impairment and risk factor for dementia.
And also, sorry, if it's particularly akathisia, there are options that are probably better than anticholinergic agents. Those tend to be, kind of hit or miss for akathisia. And so obviously there's propranolol, which has been shown over the years to be somewhat effective in akathisia. Benzodiazepines, as Christoph mentioned. There was something a little while back looking at mirtazapine that seemed to have roughly similar efficacy to propranolol, and other than sedation and weight gain, which obviously is an issue, was better tolerated in some ways than propranolol. And obviously, if you can't tolerate propranolol, that could be another option. And so particularly if what they're struggling with is repeated akathisia, then I would probably look beyond the antimuscarinic agents to try to treat the akathisia, assuming they're getting efficacy with the agent.
Got it. And you mentioned too mirtazapine as something that could be helpful. If propranolol has been tried, mirtazapine itself, is that something you would recommend dosing? Usually, I imagine it's usually at night, but during the daytime.
Yeah, certainly. It's got a long enough half-life that you should be able to just dose it at night. And in this, and in the study that came out a few years ago, they were dosing it at 15.
Got it. Thank you. Another question from our audience is that this audience member works in the hospital consultative setting, and they comment that that olanzapine is by far the most commonly recommended agent to manage agitation. So olanzapine often ends up staying on their medication list after discharge. Can you suggest a better strategy with, say, an intramuscular option and good immediate efficacy for agitation, but that's safer for the long term?
Well, this is fairly close to my practice setting, and so I'll give this one a try. When you're looking at acute agitation, I think you really want to separate what you're doing in an emergency with what you're doing right after the emergency. And so, there are other options. They may not be as good for acute agitation, right? I mean, you can get aripiprazole in an acute IM. You can get ziprasidone in an acute IM. But those drugs, we don't know if they work quite as well as giving someone haloperidol with lorazepam or, IM olanzapine. And, I think there's a reason that we reach for IM olanzapine and IM haloperidol, because we have much more experience with them and much more of a sense that they're going to work in an acute setting. I certainly see this where people get started where people get that in an emergency, and then the idea is, oh, well, olanzapine worked in the emergent setting, and so we just continue it. And, I would say we just have to be kind of vigilant on that one. If they're working in a consultative service, there is a difference between what you use when the patient is, tearing up the plumbing, and then what you give them right after that to try and get long-term control. And so I guess I wouldn't necessarily recommend that they start using, IM aripiprazole for agitation. I think you do have to be able to separate, I'm using this when they're acutely agitated, and then right after they're not acutely agitated, then I'm going to pick an agent with the long-term treatment in mind, hopefully a lower risk agent if they haven't already failed.
Sanjay, what do you think about trying to start with an agent right away that I want to use for long-term care, but adding something sedating, either a benzo or a couple of days of olanzapine, but bringing in already the less side effect laden drug, so that you have a little bit of co-treatment early on, but really what you want to build up is the dopamine modulation with a drug that you can give long-term. Because what we're seeing is inpatient time is short, you give them the big gun, and then patients are discharged, but the outpatient doc actually says, well, you know what, I don't want to rock the boat, and I don't see the patient 24/7 like you did with all the nurses. I'd rather continue. The weight gain, the metabolics, not as much as a problem as if somebody goes back into the hospital. And then they may not need the bigger gun with lots of side effects if you would have tried to actually get the other agent in early.
Oh, yeah. I 100% agree. One of the things I tell my residents all the time is whatever you discharge them on is probably the thing they're going to stay on, regardless of what you put in the discharge summary, regardless of what advice you give about, hey, we started this, but we really think you should transition to this. Get that out of your head, because it's not going to happen. You need to have them on the regimen that you think they should be on. And so, so just to clarify, when I think of an emergency, I'm thinking of the person that's, taking swings at people and, and is going to harm themselves and is, hugely disruptive to the unit and is, ripping up the walls and, smashing their hands into things, right? And so for that person, the first thing I'm going to give them is some sort of big gun just to protect everybody and to shut everyone down. But on day 2, when they have been shut down, that's when I'm going to probably start the low risk agent, maybe have some overlap with the big gun that I used, but sometimes even not. Sometimes you just need the big gun on day 1 or hour 1, just to make sure they're not going to hurt anybody. And then really immediately after that, when at all clinically feasible, you should be thinking, what do I need to put this person on that I can keep them on and that they can hopefully be on next year or the year after, right? And the best time to do that, as Christoph said, is in the inpatient unit, because then you can at least gauge early efficacy. And although it's not a perfect proxy, we know that something that works in the first week or 2, i.e. on an inpatient unit, is actually fairly likely to keep working long-term. And we know the opposite too, that if it doesn't work in the first week or 2, you probably need to do something, increase the dose, switch the drug. All of that stuff, if you can manage it, should be done on the inpatient side. And then you send them out, hopefully already trending in the right direction on the drug that you want them to be on longer term.
Got it. That's great advice. And deprescribing, thoughtful deprescribing, is something that the Psych Congress family has talked about in our other sessions, certainly. So we've got 2 questions that we want to address, and we just have about 3 or 4 minutes left. So I definitely want to spend some time on these 2 questions. The next question we have is, what is your expectation of risk? What is your expectation of risk for TD, tardive dyskinesia, with lumateperone? Would you try switching a patient who has TD to lumateperone?
Maybe I'll take that one. Obviously, we don't have enough data yet for any of the switching, but pharmacologically, since it has relatively little postsynaptic blockade, we would not expect like an upregulation of dopamine receptors. It should have a low risk to begin with. What it means in terms of treating people who have established TD, I mean, we have 2 approved drugs, deutetrabenazine and valbenazine. Those have really established efficacy and would be evidence-based and guideline consistent. But to prevent maybe the onset of TD, or once you see a little bit of dyskinetic movements before it has developed full-fledged TD, these agents that have little postsynaptic blockade would be, like lumateperone, would most likely be beneficial. But we need more data.
Got it. And then the final question one of our next questions that we have is, once lumateperone is available, or once it's available, what would you recommend for a cross taper for severe schizoaffective disorder plus bipolar subtype with moderate metabolic issues? And we have some medicines that this particular case is on. So this particular severe schizoaffective disorder bipolar subtype has moderate metabolic issues, and they're prescribed 6 milligrams of Risperdal, 15 milligrams of Zyprexa, and 900 milligrams of lithium. And that it was, so again, the question is, what would you recommend for a cross taper for this patient with 3 of these medicines?
Should I try to take a gander at it and then you? Okay. So, I mean, basically, Lumateperone Caplyta is approved for schizophrenia, is not yet approved for bipolar depression. The studies were, as far as we can see from the press release, positive. So basically, you have 2 antipsychotics. One is highly antihistaminergic and anticholinergic, the 15 of olanzapine, and you have a very tight D2 binding agent, risperidone, at 6 milligrams. So I would basically see, do they need the 2 at the high dose? Why is that? Could I already maybe bring down risperidone to 3 or 2, and then bring in lumateperone at 42, and maybe get rid of the risperidone first, because they are closer together in terms of having dopamine modulation. And after then lumateperone has taken center stage, see whether you can very slowly, 5 milligrams once a month, decrease the olanzapine. That would be a very slow cross titration. But I mean, if they feel they need 2 antipsychotics, or why not another mood stabilizer? Lithium is in there. Is the dose high enough? What about valproic acid? Do you need something more from below for bipolar depression? Then lamotrigine could come in. I mean, this goes beyond the 2 minutes we have, but Sanjay, maybe you have some additional thoughts.
Well, I'll go back to our old standby, which is if they're on 2 antipsychotics and a mood stabilizer, is this someone where clozapine has been considered? If they're getting a suboptimal response from all of those put together.
Excellent suggestions. And this, it just kind of shows you how intricate and how detail oriented, knowing about all the nuances of these medicines are very helpful. And thank you so much, Dr. Correll and Dr. Rao, for joining us and for such an excellent presentation. Up next, we do have a quick 15-minute break before the next set of sessions begin. Please check out the live agenda page to see which innovation theater you would like to attend. Remember, attending select innovation theater sessions will earn you points towards our Passport to Prizes competition. So visit the Passport to Prizes page for full contest details. Everyone, please enjoy the rest of your day.
Thanks for listening. Take care. Bye-bye.